gentlemen. And thank you for braving the elements on this winter's night in Wellington. Tonight's lecture in our 2014 Winter Lecture Series is by Dr. Beverley Lawton, who is with the Women's Health Research Centre. Dr. Lawton, who's of Ngāti Porou descent, trained at Otago Medical School. She worked as a general practitioner in Newtown, Wellington for 17 years and co-founded the Wellington Menopause Clinic. These experiences led to an interest in research to answer the many questions relevant to women's health. She established the Women's Health Research Centre. In 2004, Bev was made an officer of the New Zealand Order of Merit for services to women's health. She's the national maternal, a member of the National Maternal Monitoring Group, and she was previously a member of the New Zealand Perinatal Maternal Mortality Committee and a member of the National Kaitaki Group for the Cervical Screening Program. She describes herself as an accidental academic and a clinician with many questions. Bev, the floor is yours.
Kia ora, tēnā koutou katoa. Oh, and haere mai, welcome. I mean, coming out on a night like tonight, I almost didn't come. It was so good for you to come. Oh, that's great. Now, we're going to talk about equity, and we're going to talk about women's health and children's health today. I don't know if you can all see. Let's see if I can find a place where I can walk around. Can you hear me? Yes. Okay. So this is just our space, our research space is our group, research group. We look at the maternal child care pathway. And it's very important that we look at clinical performance and systems issues. So that's where we're doing our business. We're looking, how is the clinician's behaviour, their performances, whoever they might be, and we're looking at the systems around our whānau and families. So is it transport, is it finance, is it housing? What are the things that are contributing to the health or the barriers to health for our whānau and our families? So I've got to say here, it's really important to say it's not about anything like doctors or midwives. It's not about any other profession. This is about looking at systems. It's really important that we say that because there's quite often this big discussion about pro or whatever profession. We're looking at what's happening for the woman and the family and the child and what is around them and what the performance is like. It's about quality, about best practice. We're interested to see if best practice is occurring, and we're really interested in finding the odd novel thing that we might find that is different that we can use as well. And we have lots of projects, and we're going to talk about two today. We're talking about facilitators and barriers to health. We'll link this up. Now this is one of my teammates got, this is an official pointing stick, a big stick. So this is my un-PC remark. So what we do is we point at these things. We point at the systems, we poke at them. What's happening, how are they working, how they're not working. It's not really a big stick, or lift up the edge to see if there's something that we can do to make things better. So this is our team. I wouldn't be here without a big group of people, our extended whānau, some of the places we go to, we all work together. And down the bottom there, you can just see that one down the bottom. That's the three of us on stage at a hui, and we all try not to cry as a teenager talks about her life as a teen pregnant woman, a pregnant mother, and what happened to her when she got pregnant. And so she's with us as a team talking about teen pregnancy. And it was a marvellous experience. So what is our kaupapa? Our kaupapa is all about Māori pregnant women and their infants. Their children are more likely to suffer from harm or die than New Zealand European. And we don't think that's acceptable. And we also think that there's an opportunity to make a difference. We're looking at where it's not working. And if we can look at where it's not working, an extreme example, then we get that right, then it's a lifting up of all things. So it's a great help if we look at where the things and systems and maybe clinical performance is not going right for this group, as obviously it's not. So just a little, bring us back to the facts. This is from the PMRC report, and the ethnic disparities have not changed over the last 5 to 7 years. And again, 11.45 per thousand is the perinatal mortality rate. That's babies that have died. versus 9 for New Zealand European, and Pacific is even worse. So this disparity is prevalent all the way through, 2 to 3 per 1,000. So this is not really acceptable. But this is an opportunity to see how we can improve our service. We have a good service, but I think we can be better. So in 2012, 18.5% of all perinatal deaths were considered potentially avoidable. And this is by local audit committees looking at their own cases. And we know that underestimates the avoidability by about 30%, because it's actually quite hard to criticise your own activities, your cases, when something goes wrong. So for Māori mums, 23% of their perinatal deaths were potentially avoidable, compared to New Zealand European, which is 12%, twice the rate of potential avoidability. So again, these figures don't reflect what might happen with severe harm, neonatal encephalopathy, which, if you don't know, is very severe harm. The baby is harmed due not for oxygen when the baby is born. So when we look at it, I always think it's quite interesting. We're talking about babies that have died, and we say for a mother that dies, a maternal mortality, behind that is approximately 100 what we call nearmisses. I don't know what it is for a baby. It might be the same and it might be less. We've not really settled on an amount, but this only reflects the babies that have died. So again, maternal mortality. This is setting what we were talking about with the title. The babies and the mothers are dying. Well, in fact, the title was Wahine and Tamariki are dying, but they didn't seem to think that was as good. So we changed it. So again, our maternal mortality rate is higher than the UK. It's not a lot, so that's really good. We don't have many deaths per year, but we probably could have less. The committee is an external audit committee. Approximately 34% of our maternal deaths, that is women that die in pregnancy or who are recently pregnant, were preventable. And you can see down below that there is a marked disparity for Pacific versus Pākehā and Māori versus Pākehā. Again, there's an issue here we need to be looking at. So what are our barriers to action? And I think our barriers to action is that we normalise this. We say our rates are really good, and we're good, but they're not good. We've just seen rates that are very poor. But we normalise the fact that we expect the rates not to be equitable. We expect there to be inequalities. And so if you normalise things, that means it's normal, so you don't do anything. We do deficit modelling, which we talk about. We put the blame for the death or whatever onto the mother or the baby, whatever. So we'll talk about that. So we need to reframe the issue before we can get some action. And this is the one where I always have trouble with this one. Māori have a higher perinatal mortality rate, and that's that public health term. But really, these are dead babies. And we should be reframing the issue that Māori have more dead babies. And people don't like that. My team don't like it when I say that. I don't like it when I say that. But we need to reframe it, not in terms that are... I mean, I can talk to people in public and say, let's talk about perinatal mortality, but nobody knows what that is. Unless you're used to those terms, but they know what dead is. Right. And we asked our komato, I said, can we use dead? Because it's tapu, dead babies. And you know what they said? They said we have to put it on the table before we can address it. So we need to talk about it. If we don't talk about it, we can't fix it. So we need to reject the victim blaming approach. And I think that we all do this. We all, this is the, you know, the difference. We say the book late. Māori babies and pregnant women are more likely to die, smoke. What are our women doing wrong that their babies die? Now, this one was really interesting. That's from one of our komatua after I was talking about teenage Māori mums are more likely to have a perinatal death. There I did it again, and more likely to have their baby die. And he said, what are they doing? So it's all about what is the woman doing rather than what might be around her in the way of access, clinical performance and systems that are contributing to that death. So, and I like this bottom one. A professor said to me, when Māori women have a low uptake of congenital abnormalities, this is due to cultural beliefs. There is no data. Most young women, most women Māori aren't asked if they want to have a test for congenital abnormalities. So we've got to turn it round. We've got to actually talk about what are the issues, rather than, again, if you think it's their fault because they book late, then that means that the action is moved away from the system and the clinicians. So this is what we follow for Paratini Ngāta. The late Paratini Ngāta used to say, if we get it right for Māori, we get it right for everyone. And, you know, it's a difficult concept, but it's the lifting up from the bottom. And luckily the Treasury agrees with me. You've all read the Treasury papers on this, I know. And they say that equitable or equity is one of the major pillars. Achieving equity is one of the major pillars for having a successful society, and to lift up that society so that, and it saves money. And in fact, the Australian Treasury is really into it. If they get equitable outcomes for Aborigines, they think they're going to save $71 billion a year. So they count in money, and we're counting in lives and disability. So it's a lifting up. I like that term. I saw Heki Parata do it about education. I thought, I'll steal that. That's what I did. So we use what we call Kaupapa Māori research, which many of you will be familiar with. We put Māori at the centre. We look at, we consult with our communities. What are the questions? One of the studies we did, we went out before we did the protocol. What's the problem with our young Māori mums? You know, then they tell us these six cars up the driveway to see that Māori whānau with a baby there. They might have 3 babies in the house. They're all in there with one baby, doing the ears, doing this, doing that. And, you know, you go there, and she said, you go there and you see there's a really severely ill child in the house, but they're all concentrating on one baby. And you have to, nobody's looking at the whānau as a whole. And that's where I think the whānau ora we've all heard about will be useful to address this. So what we do, we find the facts, find the solution, and we translate, we hope, results. So this is us here. Again, we look at the whānau at the centre, the system around, and the clinical issues from the provider clinicians. So the whānau is good. So you're looking out to how you can perform, how we can get a better result for that whānau, that family. So we're looking out, not in, and blaming. So I think it's really important. So I like this one. What have they got that we haven't got? This is actually Paporangi Reid, one of our really esteemed researchers. And I used to say, well, look, we have less caesarean sections as Māori, isn't that lovely? And then she said, well, you know, I said, we're less hysterectomies. And she said, well, I want to know why they're having their hysterectomies and why they're having the caesarean sections and why we haven't got them. And actually, if Māori have less caesarean sections and their babies die more, ooh, we might be onto something. So I don't know. I always think it's very interesting because there's one randomised controlled trial in Africa. And do you know what decreases the deaths of babies and the deaths of mothers? Producing a caesarean section service nearby. So you can interfere in that, natural process and salvage the mother or the baby. I know that's slightly more extreme, but if you establish that service, then you notice your maternal mortality goes down, and so does the mortality of the babies. So we have this view of too many caesarean sections is bad, but I think we're really lucky to even have that service. So we look at the root cause analysis of why there's a difference. We sort of see, because one group is privileged to have something and another group doesn't, we want to know why. We look at the systems. We're talking systems, barriers, facilitators, clinician barriers and facilitators. And of course, housing, education, finance, racism. A lot of things go into this equation so that we'll have research for quite a long time. Isn't that good? Yeah. But anyway, we use mixed methods research, so many of you will be familiar with that. We do qualitative and quantitative. We talk to people and we also add up things, so that's really quite fun. And there's 2 of them. Oh, should we do 2 of them? You'll be doing a HENE, the qualitative, and we're going to talk about a severe acute maternal morbidity audit. So this is a HENE, which is pregnant woman, Māori woman. This is a study we did where we recruited 44 pregnant Māori women, either recently pregnant or pregnant. And we followed the journey of that whānau till the baby was a year old. And they were, that was really interesting. And we've looked at bits, and this is the bit we're reporting today, is about when they got pregnant, what did these teenagers do? So we looked at the engagement with maternity care, and we wanted to know what was around her. Who did she speak to? Where did she go? And where did she get her advice? Okay, it's a qualitative study funded by the New Zealand Health Research Council, and this has been reported. We had two groups, Hawke's Bay and Wellington. Some urban, some rural, as well, two urban groups, but we had a rural group up in Hawke's Bay as well. So it was really interesting. These young women were in very deprived situations. So we were able to access them. It was really good, really. So we've done a lot of interviews. So we talked to them about their whole journey, from their motherhood, becoming a mother, their decision to have the baby. We didn't talk about their decision to be pregnant. We were a bit past that. So they were already pregnant. And we were very careful with the study that we weren't saying they shouldn't be pregnant. This is not about whether you should be a pregnant teenager. And there's enough stigma for these young women as it was. We talked about their education, whether they went to teen pregnancy school, what their social services, health services, and their hopes and aspirations. So we're talking about how they engage with maternity care with these results. We had 44 participants, 159 interviews, and they were aged 14 to 20 years of age. Okay, so this is when they started to enter the maternity care pathway. And this is really interesting because the first thought of everyone is these young women engaged late with health services. As soon as they did a pregnancy test at home or thought they were pregnant, these young women went to their doctors, their health service, their nurse at school. So they really were, really attended. There were 3 that attended later because they didn't even know they were pregnant till late pregnancy. But as soon as they were aware they're pregnant, they presented to a health service, which I thought was really interesting because that gives us an intervention point for these young women. They did home pregnancy tests, and this one here, I just had a feeling I was pregnant. So she went to her school nurse to check up and stuff. And she showed it to me, and I cried. I was shocked. I mean, these women, young women are always shocked when they're pregnant. They're never contracepting, but they're always shocked. That was a slight aside. I mean, they really are. They're always shocked to find they're pregnant. We're doing something wrong. Okay. So when we look at the maternity care continuum, they get given a list. These young women, 14 to 20, are given a list to find a midwife, which is, you know, I don't know how many have got kids or teenagers. I mean, this is a written word. I mean, they find that really hard to negotiate. They get given a list and they've got to ring up. And these young women are very lucky they'll be very lucky if they have any money on their phone. And if they leave a message, because many of the services for midwives leave a message and they'll ring you back. And if they ring back, they don't have their ringer on and they never check their messages because it costs money to check your messages. So it's a very ineffective way for them to work. And if these young women ring up, and if you're 15, 16, 17 and you're leaving a message, you know, some of these don't, but there's a lot of cherry picking. Why would you want to look after a young Māori teenager in Porirua? I mean, that would be fun, but if it's a lot more work. So there's a lot of cherry picking going on there. But anyway, they found it really hard. They tried very hard to engage, and they found it really hard to engage with a midwife. So this is doctor just gave me a paper with a list on. I tried to get to contact with some of them, but they said they weren't working around the time. And then she ended up without a midwife. Some of them ended up just walking into hospitals and asking for someone. But it wasn't that they weren't trying. They were actively seeking, which I was quite encouraged by. They were wanting to do the best they could to engage. Okay? And I think it really dispels that myth that young Māori women don't engage. They need navigation and support. And we had some stunning examples, they were few and far between, where they took the pregnant woman in front of them and said, this is what we need to do. And they walked them through and they connected them with a midwife. They didn't let them go. They did the appropriate tests and they navigated them through the maternity care pathway, which was really good, but it didn't happen a lot. And so this is just a conclusion about Ehene, the study, which we've still got lots more results to come out, particularly of their contacts with other services. They engage early, these young women engage very early with health services in their pregnancy. The barriers exist for them moving along that maternity care pathway. And I think that's what we need. We need that pathway to be integrated. These delays we thought were very avoidable. And there was also a lack of information and support. They weren't really given a lot. So they didn't know a lot. These are women 14, 19, 20. No, there was 2 or 3 14-year-olds in this. I mean, it's very hard for them to navigate their way along. So what else in the conclusions? The pathway works well when primary healthcare is fully engaged. I mean that primary healthcare in the fullest sense, from the nurses in the school right through to our GPs. We found that the expectation of them to confirm, identify and enrol with a midwife was a significant challenge for these young women. And since we published this, I've had a lot of what I would call more middle class and able family tell me it was a challenge for them to be able to get that next step. So it's a common theme. So we seem to have a lack of a seamless maternity care. I think we probably all know that. It's a bit disjointed. It drops around the place. There's a lack of primary care engagement in the first trimester care. That's the first part of pregnancy. And there's a lot of evidence that things we should be doing in that first part of pregnancy. It's a big long list. I didn't put it up. But this is when we need to be looking for congenital abnormalities, sexual health problems, STIs, that sexually transmitted infections, a lot of things we need to be doing and informing. But the most primary thing we know we've got a lot of evidence about is that stopping smoking by 15 weeks of pregnant is really, really beneficial. So we really need to be engaging really early from primary care right through. So we've got barriers there. And we've now got you find your midwife. And I think that's great. But the problem with that, you go on the website, you have to ring a cell phone number. And you have to be, a lot of these things you have to leave messages. So we have this same problem. And many of our young women don't have that sort of access to the internet. They do have a phone that can do things, but this is actually quite complicated. But it's a great tool for people to navigate the young woman for them, having someone to navigate them. So, I'm getting on to get general practice again. I think we've got to realise that when this young woman walks in the door, that teenage pregnancy is a high risk, that we need to surround ourselves, this whānau, with some support. So lights should go on, and these women should be well supported. From primary care, we need an integrated, seamless maternity care pathway. We need to reduce that fragmentation. The first time they had a health service, these young women think they've started their maternity care, and they have. There's a payment for that first maternity care by the government, and that's when I think they need to walk them through. So I like that primary care needs to step up and become involved in maternity care. It's very important. At a minimum, they have to do the first complete set of service for that young woman, for any pregnant woman, and then navigate them along that maternity care to a midwife, obstetrician, or a hospital service. And I think that would make a tremendous difference. So, more of this. I think that this is my new thing. We're saying pregnancy care starts with the first health service interaction. And that's when that care, and that's when that young woman thinks she's starting with her care. So we need coordinated messages and protocols across multi-sectors, which isn't happening at the moment. And we need to explore the maternity care model to see what are the drivers of this fragmentation. Do we need money here, or do we need something here? we need to look at the funding model. And accurate data collection. I think this is really quite interesting. You know, we talk about registration with a midwife being, you know, that's when you start your pregnancy. But in fact, that's a piece of paper that is registered with the government for a funding requirement. What we need to do is registration with the first health professional that sees them in their pregnancy. And that will give us a true reflection of what the service is going to these young women. Because it doesn't reflect service at the moment. We need accurate data collection, that first pregnancy assessment. One of our hospitals, because you know there's a big thing about booking with a midwife as soon as possible. One of our hospitals, when people can't find a midwife, they ring the 0800 number, they get the hospital, and the hospital takes all their details and tells them how to ring around to get someone. Again, same problem. And then when they come back and say, I haven't found someone, they say, oh, we'll see you. And they won't see anyone before 12 weeks. They've missed smoking, they've missed congenital abnormalities, they've missed all sorts of things to engage with this young woman or whoever's on the end of that phone. And guess what they do? They score that as, they say that that is where they registered for care from the phone call. So the phone call comes the date of their registration, not the date of service. So we've got to be very careful we're getting a date of service if we want to really track what's happening with our maternity service. People disagree with that, by the way. So we need quality audit rather than attendance audit. At the moment, we audit maternity service. Whoever gets paid, the government pays you money, they audit it by saying, you said you saw someone on such and such day, and it's either yes or no, and that's audit. It's not what you did that day, it's just whether you saw them. And I don't think that's the sort of audit we need for these sort of very important services. So, not that I feel passionately about this. Oh dear, we need communication with stakeholders. I've got the integrated maternal child pathway again because I keep repeating that. That's a good one, I reckon. We need to correct the myths about our young whānau. They really seek positive seeking health behaviours. We need to get some change. And we need cross-sector involvement for housing, health, education. Because it's not just there. This is a chance to grab these young women because they have a lot of high needs and so will their babies. So I just want to acknowledge our participants, the Health Research Council, the Ministry of Youth Development, paid for our teenage rupu. We have a teenage group that advises us, and our kaumātua kahui. We've got quite a lovely group of kaumātua who have followed us, and our elders have followed us through and given us lots of advice. So it's been really useful. I put this in because it's another little thing I forgot to talk about last week. I think it's really important that when we talk to people, we convey the idea. We tell them all these things and they walk away. And whose responsibility is it that they understand? I think it's the clinician's responsibility to convey information. And it's just like, you know, it's our responsibility if they don't speak English to get a translator. And I will tell you that I have seen some amazing examples from our maternal, you know, really severely ill women that have done so well because their hospital has done translator, translator, translator. Beautiful plan. It all goes to custard when they can't understand you. And that is the clinician's fault. And something I feel firm about. I've got this HPV. Oh, I had a really good example of this. It doesn't reflect well on me, actually, but I'll tell it anyway. I was going around to schools and we were talking about the human papilloma virus. You know, the cancer virus that we give, that people get. They get Gardasil, the young women get it. And I was giving a lecture to all these college students, all the girls, they were all segregated, telling them all about this virus and it stopped cancer and it's... And at the end, I was so proud of myself at the end. And do you know what the first question was? What is a cervix? So whose fault was that? It was my fault. And, you know, the rest of it might have been just whatever I'd said, we meant nothing because we had to go back to convey it in words that they understood. And I will forever remember the teacher trying to explain where the cervix was. It will be just joy after that. But we've got to be, you know, it's all very well but they've got to be able to understand us, and that's our responsibility. So this is the second study, which is another one we love, actually, I'll tell you about, which is what we call SAM, which is severe acute maternal morbidity. So these are women who almost die in pregnancy. This is funded by the Ministry of Health, and the subsequent one is funded by the Health Research Council. So big team, lots of clinicians and the research team, and our kaumātua, who often comes and talks to us about this, because these are very serious issues. So it's a near miss, or a severe acute maternal morbidity, a very ill pregnant or recently delivered woman who would have died had it not been for luck or good care or management on her side. And that's when these women are really, really sick, there's a lot of luck involved in them not dying. So good management. We had one case recently where the committees just went, oh, that was so good. And we really only had that once. It was just terrific. They'd done everything. And Indigenous people worldwide are more likely to have a SAM event or a near miss. So this is of interest to us. This audit will describe 4 DHBs, which about a third of New Zealand deliveries we audited. It was an external audit. So remember we were talking about internal audit, not as good, because they're not so critical. This is a group of people who are auditing cases that aren't their own. So it's external audit. We looked at these women who ended up in intensive care or a high dependency unit. We used a multidisciplinary team. We used the definition by an international, Professor Geller, for an international definition. Any action or inaction on the part of the healthcare provider, the system, patient, or a combination of these that may have caused the progression to more severe morbidity or harm. So a woman might have a postpartum hemorrhage where she bleeds. We can't necessarily stop that, but it might get worse and worse and worse, and she almost died. So can we bring it back earlier so she doesn't get so sick? So can we stop the progression of harm? And that's what we're interested in. And it's based on this concept, which has been proven overseas, is that the sicker you get, at the end there, it's like tossing a coin. But back here, then they might die. It's a lot of luck involved in surviving when you get that sick. But at this level, there's a lot of management that can be done to bring that back. There's less luck. So it's based on being sick as a continuum before you die. So this is what we found for this. This is just 98 cases. And we found that 75% were deemed preventable by our external audit committees. They were anaesthetists, midwives, obstetricians, intensivists, we've got the odd GP, midwives, everyone was there. And they were all working together. And it's a really nice experience to get all this expertise contributing. So 75% were preventable or needed improvement in care, with about 40% deemed potentially preventable. So and this is very worrying, but in fact, this is in line with some of the overseas audits. But we've got a baseline now, so we can do things to change that. I just sort of put in the baby outcomes, which is something we've become interested in as part of another study. 18 out of these 80, 18 out of 80 that we looked at, the first 80, had a pregnancy loss. So 22% of the babies died related to these pregnancies. They have a high rate of baby loss. Of these deaths, 6 of the women had a potentially preventable SAM events. 14 of the live births had low APGARs, which means that they were low oxygen. The babies were harmed at birth. And 13 of these 14 were associated with preventability or improvement in care. So we're just sort of thinking about the baby. There's the mother and the baby. Generally, if the mother's very, very sick and the baby's still on board, the mother takes preference. But wouldn't it be nice if we could figure out a way that we could do both? Possible, is it? So What were the preventability factors that our multidisciplinary team found? The majority were provider or clinician error. The delay or failure in diagnosis, so if you don't get the diagnosis right, or you're late getting the diagnosis, there was a delay or failure in recognition of high risk. This is not uncommon. They didn't realise that the woman was trying to die on them. They didn't realise that the blood pressure was going down and the pulse was going up, and why was that significant? And you have to have bled a lot if you're bleeding for that to happen. So they didn't recognise it had gone from normal to abnormal. And I'd like to repeat again, this is all clinicians. This is emergency departments, this is primary care, midwives and obstetricians. It was across the board. A delay or failure in treatment. But of course, if you don't get the diagnosis right, you're not going to get the treatment right. So these sort of things are very much connected. So the commonest preventable reasons for admission to intensive care for these sick women was blood loss and septic shock, which is interesting. And we have had 2 deaths from septicemia in the last 2 years. Last year was 2012 and 2011, the last report. So I just thought there's a bit on major blood loss. So this is greater than 2 litres. That's a lot. This is in 44 of 98 cases. 75% of those cases were deemed either preventable or improvement in care. So we've got a bit of work to do around that area. And that's what we need to translate this. So the themes on the blood loss, there was underestimation of blood loss. They didn't realise that this woman had lost so much blood. Poor recognitions, as we talked about, of signs of low volume. Hypovolemic shock means they didn't realise that they didn't have enough blood running around, and they went into shock. They'd lost a lot. And they didn't activate something called the massive transfusion protocol, which some of you will be aware of and some of you won't. Every DHB, unfortunately, due to sad things that have happened in the past, now has a massive transfusion protocol. So they activate it, they ring up and call a massive transfusion protocol, whichever way they might do it in their hospital, and that gives them not only all the blood products they need, it gives them people. It says to the hospital, we have an emergency, we need blood, we need people, we need things, we need help. And what they didn't do was activate this when they realised they're in trouble. So they needed to activate it. So that was one of the things we noticed. Inadequate resuscitation, that means they didn't give it enough fluids. In most cases, that meant they didn't give enough fluids. They didn't make the woman well enough, quick enough. Again, they didn't realise how sick she was. And they used small cannulas. You know, you put a little cannula in, you need a big one to put bloods in. I know that seems strange, but some hospitals have actually taken all the small cannulas off the delivery suite. So if you put one in, it has to be a big one. So that if something goes to custard, you'll have one in, and that's really important. I know there's things. And a failure or delay in calling a consultant, and that was a consultant, either a consultant obstetrician or a consultant anaesthetist, because they're experts. Hand over the blood loss onto them. They can pull things in. So, I mean, so there were the things we found. And so what we do with these things, these are learning things that we can translate into education and activities. I'll keep stressing these areas across all sectors, but I want to see there were some strengths of this. This is multidisciplinary audit. This is a sector, the maternity sector, has not really been sitting down a lot together until the last 5 to 10 years. They're sitting down, they're working together on these cases and working really well. And it's been really good. They sit around the table, they look at the cases, they're anonymous, they don't know their ethnicity, they know they're female, I thought that was a good one, and they know their age. One of our clinicians said that to us. I thought, we got you there. And it's anonymous. So they don't know the person and they don't know the ethnicity. And they work very collaboratively. It's a very satisfying process. Everybody enjoys it. So where do we translate this into action? Getting something to happen to solve it. We get several bites with this audit process. We get the individual clinician's performance and teaching. We get the clinicians sitting around the tables taking their learnings back and to their teaching and their own performance, and we know we've recorded that. We get a driver for transparency and change. People get more accepting of looking at when things go wrong and when we can make it better next time. We've gone on to a national audit, which we've begun now. We've now got 14 DHBs enrolled, so that's pretty exciting. The themes we mentioned can lead to interventions, or they can be used by various DHBs for their teaching. And eventually we'll be getting a big DHBs will receive their themes and their score chart on preventability. And that will be probably confidential, and publicly there'll be a national score chart and the themes. And I think that's part of our accountability in New Zealand, which is really good. The hospitals tell about their central events. We know when the mistakes are happening, and that can only be good. So our goal here is to make this audit process business as usual. And so we've got funding from the Health Research Council, the Ministry of Health. If we can enrol all these DHBs, and they're all saying yes, and roll it forward, is this a good thing for New Zealand to pay for? Because it's not cheap. But of course we think it's really cheap. We think it's very reasonable. So what are we doing? We're chasing equity. We want to bring together, we want to lift up the results. Sometimes I worry we're saying, do we want to bring everyone down to make it like, we want to lift the results up. We want to have less harm for our babies and mothers. I want to talk about the power in words. We need to talk about words that create action. Really, and that's what we're not doing at the moment. We need action. I like the way that we're collaborative. We're across our professions. I've already talked about framing, and it depends on the audience who you're talking to, depends on which audience I'm talking to. But this is such a good audience, I'm framing it just like this. The argument of treasury versus rights, this is an economic imperative to get this all right, to get equity. Is it a rights issue? Is it a treaty issue? I think it's probably all of those. But there's no doubt about it, we can do it a lot better. So what do we do moving forward? I think we need to understand disparities, because these really are disparity studies. We believe that if we address that issue, then we'll find those little things that we need for the whole system. We need to look at system, provide a clinician model. We need to have system and clinical accountability. And system might be to the fact of even having transport for someone to attend a doctor, to have a system where you can have reasonable transport, where the ambulance doesn't have a protocol that says they can't have lights on unless they've talked to 3 people for a sign-off. We need to have systems that work for us. And I think there's greater buy-in for this sort of examination of our work from all professions, and that's been great. From this, we can create solutions, some actions for change, and I think we can always get better, and I think that people don't like it when I'm up there waving my stick. It's not a big stick, it's a little stick. Sometimes it's a big stick, saying we need to get better, because they take it as a personal insult. But what really we're saying is that we can always get better, and there are problems. I'm sorry, there are problems when you see the stats, when you see the fact we see 75% improvement for these severe cases. What are they like for the less severe cases? And these are our families, our whānau. In fact, I've tried to persuade my daughter, it could be you, dear. Not having harm, but at least having a baby. But they don't listen, I don't know these kids. So we can always get better. And this is what it's all about. It's about improving our quality service. So I might have something else to do. Oh, I do. We were challenged at Hui Whakapiripiri, which is a hui for the HRC last week, by Professor Linda Tuiwai-Smith. She challenged us all to be the best researchers that we can be, and I thought that was really good. And then I think we should challenge our maternal child care pathway to be the best pathway that we can. And why? So that she can be the best that she can, so that we can get all our children the best start in our life. And I think that's my last slide. We rushed through that. Thank you very much. There's no question?
Thanks. Thanks, Pete. Thank you. We will take some questions and answers.
If you like, yes.
Yeah. Be good for people to be able to ask you. So.
I'd like to know, to improve the result, do you need more funding from the government? And how is it like?
I think there would be. I think it would be really nice to have some funding directed towards integration, and that's what we have been talking about. So do we have more money for midwives to do that first trimester, to GPs to do that first trimester, and to link it through? If you're talking about our young whānau, quite often there's money and pots out there to support them, housing, all the other things. It's how do we navigate that to them? There's a lot of issues about connectivity that we're talking about. But yes, do we think we need to have more money for maternity service? Yes, probably.
Hello. In the first slide, I saw that the Indian rate is also high,
Yes.
even higher than anyone
Yes.
else.
Yes,
And
well spotted.
yeah. So, what was the reason for that? Yeah.
That is a very good question. I don't know. The numbers are small. They still are small, but there seems to be a consistent outlier. Now, I don't know. And is anybody looking at it?
Yeah, that's my
No.
second question. Is it because of the culture that Indian culture is still hiding those things and doesn't?
Well, I'd like to think if we're looking at our model, it's to do with systems and barriers. And it might due to the fact that they're not getting their culture accepted in a way that we can communicate. So it really is it really is the system that should accommodate that in some way.
Thank you.
So on that model.
Thank you.
Yeah.
I don't know much about this process, but do midwives have a place where you can go, or do they only come to your home? And if so, if they come to your home, is there an awkwardness around that for the young women? And once they've been there and the woman's met them for the first time, if she doesn't particularly gel with that midwife, is she comfortable about changing midwives? I mean, I'm just thinking of going to a doctor's waiting room, there's pamphlets, there's posters, you start chatting with other people. So is that opportunity being lost with the system that's in place at the moment?
Well, this particular bit we're talking about is that getting from that doctor's to the midwife was the problem. I think most of our young women were very happy with their midwives. It was about 2 that changed. But I think that it's a good service, but they've got it to getting on the beginning, because it's a maternity care pathway. From the time they're pregnant, they need services. So we need the services, whoever does them, to come with them as they walk along the middle. So they shouldn't have to walk around like that.
But does the midwife go to their home?
Midwives can go to homes, and they also have clinics.
Oh, they do have
So some have
clinics.
clinics at various
That's my
places,
question.
and some go to the homes. They all do different things.
Bev, congratulations on getting to the nub of the matter. One could ask all sorts of questions like, have you tried doing it on income grounds and all that? But I think regardless of that, it almost doesn't matter. You've pointed out where the gaps are. And so I think my interest is the sorts of things we've set up these days are highly fragmented, which works against communication. Communication seems to be at the heart of this, and it need not cost a lot more. It's just that once you've pointed it out, that you really need some easy transition from the woman to, instead of just getting a list, to actually perhaps be sent to a real person who can help her navigate into the midwife system, that sort of thing. But the point is that with everything divided up, does that actually cross a kind of responsibility boundary, for example? And does it help if you have some suggestions as to how some of these things on the edge of one lot of responsibilities and another could be incorporated? It's not really your job to do that, but it seems screamingly obvious that this sort of thing is needed.
Yes, well, we've been talking about that integration pathway, that there should be a payment for the first health professional to actually navigate that person. It could be the nurse. The nurse can sit down with find a midwife, have that relationship, and then make sure that young woman is anybody, not even that young woman, because this will extrapolate to other people finding a difficulty, so that they have to walk them along that pathway. We sort of thought, well, we're doing a lot of pushing to go and see your midwife as soon as possible, but we have 66% of our pregnant women are now presenting first to their GP. So we should take that group and really do the business and get that first health event, the smoking, everything done, and walk them along to the next step. So that she's walking along like this and everybody's helping as she walks along, rather than having to go and divert. Yes, there are some ways, and we're working with 4 DHBs on this at the moment, because DHBs are very keen to get this integrated pathway working.
And they need to be walked along too somewhere.
We try. I think everyone's walking together on these issues, which is good. I'd be very polite in politics tonight.
Yeah, thank you. I was harking back to the Indian case that the other gentleman down there observed. I observed it too, and was taken by your comments on equity. And it would seem to me that if you're benchmarking or you're looking for a place to start the improvement, and if you fix the least of our brethren, you fix it for everybody, I was wondering why, more effort didn't go into that one, because it would seem to me that if you could bring that up, it would bring everything else with it.
I just forgot to mention it. The numbers are very, very small. So the bigger group is Māori and Pacific. So if we get that right, I think a lot of the problems for Indian will be helped as well. And there might be some particular problems around that as well. So I think that is possibly of use, but it still will be helped by these extra communications and these literacy issues.
Yeah, I was seeing it as more identification of issues rather than whether they were Indians or anybody else. It was just because the numbers were more containable. You might actually have a faster route to improvement by picking the worst case. That was the thought. I mean, if you're benchmarking, that's what you'd probably do.
Yeah. But I think that's a good point. There's not many Indian teenage pregnancies.
Yeah.
Well, those weren't, they were all, you're right, yeah.
I was aware from the Children's Commissioner's report about some on women and I think something like 30% of them didn't get any LMC care, that they were receiving their care through the hospitals. So can you say anything about is that inferior care? Is it, the model that most women have is the LMC model, but we know that there's a significant number of Samoan women who are only receiving their maternity care through the hospital clinics, and it also seems we don't collect as good data on that, or at least it's not as available. The trimester of registration for the hospital maternity care isn't published along in the same way as the LMC data was, so you can't see how many women only registered at the very end.
Complicated issue.
Yeah.
85% of our pregnancies are now registering with an LMC. So we have a high rate of registration with LMCs. Okay, there's the other 15%, there's something like 14 or 13% we presume are DHB registrations. We don't have a lot of data, but we will have in the future about those pregnancies as they start to go into the main database. I think that I would sort of sit back on the Pacific one, because again, what we're doing is picking up registration with a service. We're not picking up where they had their first health event. And if you're talking about something like Kaupapa Manukau, they have a number of wonderful, innovative schemes that involve the DHB producing their own primary care, having primary care midwives going out. We have hubs with GPs and midwives, plus we have direct hospital care. But that hospital care is only for very high risk, which there isn't that many. You have to be quite high risk to there. So I don't think we really know that, how many are coming in, so whatever. A lot of the LMC issues that we're talking about with going to the hospital are the same issues we're talking about with our young women. They've got the same issues using a list to find an LMC, and many of them live in deprived areas where there are a lack of LMCs. So finances comes into it as well. So, there's a lot of issues there, and we should be unravelling that. But fortunately, we're not really in those areas, but Kaupapa Manukau's doing such a good job and looking into that at the moment.
Hello, Bev. I've been an interpreter for a Eritrean refugee family, and what I've found is that with health providers, right through the LMC model, that it doesn't matter whether it's general surgery or others. The problem is that the people are speaking to them in ways that they just can't understand. And we'd emerge from a meeting and they'd say to me, Johnny, I didn't understand anything. And of course they won't say they didn't understand, so we'd have to work it through. But I mean, the people are just speaking to them in language that is just way beyond their abilities. And they're often, they don't want to say, I don't understand.
And I think that happens a lot for everyone.
And it's just, and it might be the speed, it might be the accent, but primarily they're just speaking in such sophisticated English. And if they, or they go the other extreme and speak to them like a baby and completely miss things out, and you think, well, that's, it's one or the other, and I just feel really sad.
Just a comment on that. My 81-year-old mother told me the other day about her visit to her GP and was telling me that, the doctor would ask her a question, and every time she started answering, the doctor would start typing, so my mother would stop talking because she thought it was rude. So levels of confusion there that I'm sure translate. Bev, I'm aware that Counties Manukau did a maternal health review.
They did.
And I'm wondering about any linkage between your SAM work and that Counties Manukau review. Is there any joined-upness there?
We've got Counties Manukau as one of our hospitals that we are doing their SAM reviews. It's an anonymous review under Protective Quality Assurance Activity. So we won't be able to say that you did this case wrong, you did that case wrong. But what we will be able to say is these are the issues in your hospital. They might be blood loss, septicemia, themes might be A, B and C. So we can say that back, and that's the step where we're now starting to get to. We're not there yet, but we're in the study, and I think that will be worthwhile. So we're looking for themes. We're not looking to blame a clinician or other. They should be doing sentinel event reviews on these cases. So every severe case should go through a root cause analysis and a sentinel review. We know that's not happening to all of them, but as we get the process going better, I think that'll start happening internally. So they'll have an internal and an external review, and we're looking for the big themes that we can address. So.
In your Hine study, did you talk to them about contraception? At what point contraception was discussed with them, and if you followed them up to 1 year, how many of them had contraception discussed and were able to follow through with the plans that were made?
Well, we're just doing that stuff at the moment, actually. We're just doing that data at the moment. And yes, they all had many contraception contacts before they got pregnant, but weren't contracepting, obviously. They had some discussions during pregnancy and some discussions afterwards. I would say that, I can't tell you exact percentage because it's qualitative, not quantitative, but almost all, if not all, had not been on contraception by the time they'd left 6 weeks after their delivery. I won't tell you the percentage that have been pregnant again since then. Yeah, so. No, we're not doing that well either. You're doing it well. They should be, well, you're young one in your hospital, putting them, that's another issue of when we see someone and they're asking for something, we should contracept. If they want a contraception, they've agreed to it, we should be doing it there, because if they've got 3 children or 2 children at home, to get back into that hospital and to get that is very expensive. We had a woman recently who was one of these teen pregnancy. She had 3 children and she needed a contraception, but it was going to cost her $250. And who was going to look after the children while she was getting it? And she had no transport. So we managed that by providing transport. We even offered to look after the kids, but she didn't trust us. So we had everyone offering to look after the kids because she was desperate. She was seeking contraception. We are not giving her contraception, she wanted it. And I think that's the important thing. These young women are seeking this is health behaviour, they're seeking it. And so she ended up with her contraception because everyone worked together and we just paid the taxis. So I mean, in that sort of sense, we got round that. We got round that within 3 days. So you can get round these barriers for these young women.
Any further questions?
We've questioned them out. A lovely audience.
Yes, yeah, no, it's been great. Well, Bev, I think it's been a really fantastic lecture, and I think again it just highlights the extent and breadth of research that is being undertaken at through the University of Otago. So I'd just like everybody perhaps to thank Bev for giving her time tonight.
Thank you. And thank our baby.
Just our next lecture is on Wednesday the 6th of August, and it's Professor Colin Campbell-Hunt from our Division of Commerce, the Department of Accountancy and Finance, and the title of his lecture is Climate Change and New Zealand's Economy, Where It Is Heading and What Can We Do? So Professor Campbell-Hunt looks at the challenges and opportunities that climate change will bring to the New Zealand economy and argues that we should play a leading role in responding to this global challenge. So that's Wednesday the 6th of August at this venue, 6 o'clock start. Thanks once again, Bev. Thank you.
We're going to have a cup of tea.
You're welcome to join us for a cup of tea and some nibbles and to meet Bev.
Do you think we should repeat this for that?